Well, I'm excited to be talking about drug-induced kidney injury in the ICU. We're going to talk about the mechanisms for it, maybe what puts a patient at risk, how we might think about diagnosing it, and different types of management or more likely prevention strategies. So I quite like talking about drug-induced kidney injury because it's important part of patient care, and it's important part of what I do for my research to try to prevent that drug-induced kidney injury from occurring. So for today, we want to just talk about how to organize drug-associated acute kidney injury. How do we think about it by mechanisms? What's the different type of injury that drugs can cause so that we can classify it and talk with regards to different phenotypes. We want to think about the deleterious risk modifiers. What puts somebody who is at risk for developing acute kidney injury? What kind of sets them over the edge so that they actually do develop the acute kidney injury, especially after nephrotoxin exposure? And then we're going to talk about the management strategies. And this I'm going to be a little bit more broad. I've been introducing the concept of nephrotoxin stewardship. So how do we do a whole program at your hospital so that you can prevent drug-associated acute kidney injury from occurring in those patients who are at high risk? So not just being responsive to someone who develops that type of damage, but to preventing it. And we do that by some very committed, rigorous, hypervigilant monitoring. So why do we want to talk about acute kidney injury? So acute kidney injury occurs in somewhere between 8 to 23% of hospitalized patients. But that number goes way, way up when we're talking about patients who are in the ICU. I think as high as 65% of patients could develop acute kidney injury. Again, from an epidemiologic standpoint, these numbers vary so widely depending on the definition that you're using and depending how high risk the patients are that you're evaluating. But it can't be overlooked that acute kidney injury is common in hospitalized patients and even more so in the ICU. So the other interesting part to this is that about 1/3, somewhere between 20 to 30% of cases are associated with drugs. So if I'm talking about those hospitalized patients, or if I'm talking about those patients who are in the ICU, 20 to 30% can have one of their AKI events associated with the drug. This is so highly important because it's potentially modifiable, right? I could have altered the drug the patient was given. I could have potentially altered the dose the patient had received. So maybe they never developed the acute kidney injury because they were better managed. So we're talking about this because it's an opportunity for prevention. And the significance of the drug-associated acute kidney injury can't be overlooked. The fact that in hospital mortality and or patients who go on to need dialysis within the hospital, irrespective of etiology, if it's drug-induced or sepsis-induced or for whatever other reason, the in-hospital mortality and the dialysis rates are similar for these patients. So means, this is a pretty significant event that can result in substantial harm to patients. So again, our chance to step in, modify, so that maybe we can prevent this from ever occurring. Now, drug-associated acute kidney injury is also classified as an adverse drug event. By definition, an adverse drug event is harm that's associated with a medication. And so that's exactly what this is, right? Drugs that can damage the kidney, that's harm to the patient, and that's an adverse drug event. Also remember, those individuals who develop acute kidney injury are also at risk for other adverse drug events. About 2/3 of drugs or their metabolites are renally cleared. And as such, if a patient develops acute kidney injury, it cannot be cleared. The drugs that are renally eliminated are not cleared. And then that drug accumulates in the patient's body, and that can result in a different type of adverse drug event. So drug-associated acute kidney injury is an adverse drug event, but also those patients who develop acute kidney injury are at risk for other types of adverse drug events. So, when we think about classifying, or we think about, and I'm sure when you're assessing a patient or you're writing about what's happening with the patient in a medical record, we oftentimes think in terms of pre-renal, intrarenal, or post-renal damage. That's a typical classification system that's been going on for decades. The problem, or what's been really pointed out as a major limitation to this classification system, is that just because a patient has pre-renal acute kidney injury doesn't mean that there's no intrarenal damage going on. So it's probably not as easy just to put them into this individual classification system, either as pre, intra, or post. What starts out as pre can have some underlying intrarenal damage as well. And so a new classification system has been proposed. And this is a journal club. So if you look down here at the reference by Osterman and colleagues, this is a recent publication. If you're going to read an article, this is the one I would encourage you to read because it discusses this new classification system. This was developed by a group called ADQI, which is the Acute Disease Quality Initiative Group. ADQI meets maybe once or twice a year to address different types of kidney nephrology related issues and develops consensus statements around those issues. For example, they developed acute kidney injury management for COVID patients, within the last couple of years. They've developed them around sepsis. We're meeting again in June to discuss acute kidney injury related to critically ill patients and develop some consensus recommendations about management for those patients. So this group is so active in trying to advance and be contemporary with regards to management for acute kidney injury. So when we got together to discuss this, it was how do we reclassify? If these are limitations associated with pre, intra, and post, how do we reclassify this system? And that's when we start talking about this idea about function versus injury. So if you see in the upper left-hand corner, we have a situation where we're biomarker negative. And here when I'm talking about biomarker negative, I'm talking about kidney damage biomarker negative. If the patient's kidney damage biomarker negative, but also functional biomarker negative, so there's no increase in their serum creatinine or urine output, then this would be where you want the patient to be, right? And so let me just give you an example of the damage biomarkers I'm talking about. Some that people might be familiar with are some called NGAL, other one called NAG, some KIM1, which is kidney injury molecule 1. And then I say this one pretty quick, but the brand name, which I usually don't try to use, but it's called Nephrotoxin in the United States, but it's called TIMP2 IGFBP7. And so I say that rather quickly, but TIMP2 IGFBP7. And these are all stress damage biomarkers. So we're looking at the stress damage biomarkers. We're looking at the functional biomarkers. Again, this is where you want the patient to be in this peach-colored square in the upper left-hand corner. And so if the patient becomes biomarker positive, so damage biomarker positive, but they're still functional biomarker negative, their serum creatinine is still normal, their urine output still appropriate, this is what we call AKI stage 1S, or AKI stage 1, it's called subclinical acute kidney injury. So the serum creatinine has increased, urine output hasn't decreased, but they do have a damage biomarker that's positive. Okay, and in the lower left-hand corner, we have someone who's biomarker negative, but there's an increase in their serum creatinine and a decrease in their urine output. Okay, and that would be AKI stage 1A, 2A, or 3A. So if you're familiar with the KDIGO guidelines, we've used the KDIGO guidelines here, but modified them slightly to include now 1S, 1A, 2A, and 3A. And then if the patient's damage biomarker positive plus functional biomarker positive, increase in their serum creatinine or decrease in their urine output, they'd be AKI stage 1B, 2B, and 3B. Okay, important to note the arrows that go between them. This isn't stagnant. Someone doesn't just get into one of these category classification systems and then doesn't move. It's quite realistic that someone becomes biomarker positive and then they are functional biomarker negative, but they quickly have some functional damage as well at some point in time. So then they'll switch over to the lower box on the right-hand side. So you can flow easily between these depending on what's occurring with the patient, if they're getting worse or if they're getting better. Okay, so we're talking about drug-associated acute kidney injury, but I wanted to introduce to you that new schema or the classification for thinking about drug-associated acute kidney injury. And so I had said that you could easily float between these boxes, right? You can easily pass through between these boxes. If the patient is exposed to a deleterious risk modifier, they could get worse. They could easily go from injury without dysfunction to dysfunction and injury. Okay, but if you have your nephrotoxin stewardship going on and you have some interventions to mitigate that risk, maybe they actually get better. Maybe they go from this dysfunction and injury to injury without dysfunction or dysfunction without injury. Maybe they get better. So again, you can cross back and forth between these boxes depending on if you're doing some mitigation strategies or the risks actually for these patients increase. So what makes them go back and forth is susceptibility factors. What makes the patients more susceptible to increasing or developing more damage to the kidney. So if you're familiar with the KDIGO 2012 acute kidney injury guidelines, the KDIGO is the kidney disease for global outcomes group. They develop a lot of consensus guidelines. And this AKI ones have not been updated since 2012. But in their table 3, they discuss susceptibilities and exposures. And here's what makes patients more susceptible to developing acute kidney injury. If they're dehydrated, advanced age, gender, race, previous chronic kidney disease, diabetes, hypertension, cancer, anemia. In the exposure category, if the patient develops sepsis, undergoes critical illness, circulatory shock, burns, trauma, and of course what we're interested in today is nephrotoxic drugs. So greater exposure to nephrotoxic drugs can increase the potential for acute kidney injury. So these are the susceptibilities and exposures that puts a patient at risk. So when we're talking about classifying these drugs and looking at this, again, classification system that's just been introduced recently, I'm trying to think, how do drugs fit into all this? That's the question. So if we start with this upper left-hand corner where we're talking about neither dysfunction or injury, what drugs would those be? Well, the drugs that aren't causing nephrotoxicity. I call these my drugs by exclusion because they don't fit into the other boxes. They're not causing dysfunction or causing injury. So an example could be something like digoxin. Digoxin is cleared renally, but it's not nephrotoxic. So that might be an example of a drug that fits into this neither dysfunction nor injury category. If we move down to the lower left, we're not start talking about dysfunction without injury. Think about a drug that's causing dysfunction without any injury. Well, we can think of drugs that cause some intraglomerular hemodynamic effects, such as ACE inhibitors or ARBs. We've seen some of these effects with the newer SGLT2s as well. And so really dysfunction without injury, we've gotten to what's called permissive acute kidney injury or a permissive hypercreatinemia. When we start an ACE inhibitor in an individual, we expect for the function to decline, but their overall outcomes do still improve. So there's an acceptability for a 30% decline in the patient's baseline kidney function. This is acceptable because it's dysfunction, but there's not injury going on at that point in time. And so that's why these particular drugs are classified there. If we go back to the upper right-hand corner, we start talking about injury without dysfunction. And I would say this is where the majority of nephrotoxins are categorized. Right? We're talking about those drugs that cause direct kidney damage, either from some type of filtering of the nephrotoxins. It could be from some tubular obstruction. It could be for some allergic reactions. And we're going to talk a little bit about this category in a little more detail here. So I said injury without dysfunction, and you can see that on the left-hand side here. And I said it could happen for different reasons, right? It could have happened for some allergic type reaction. So the patient develops acute kidney injury, and specifically maybe acute tubular necrosis or an acute interstitial nephritis. And the drugs that are associated with this type a mechanism for injury are aminoglycosides, amphotericin, vancomycin or NSAIDs, all in the ATN category. We have the AIN, when you're thinking more of that allergic type reaction, penicillins and cephalosporins, and PPIs are also listed here for proton pump inhibitors. We have tubular dysfunction, and that can be associated with cisplatin, ifosfamide.
Excuse me, Sandra, can I interrupt you by asking a question? This is Khalid Farouk.
Sure.
Yeah. Speaking about the drugs that causes injury without dysfunction, as you said, ARBs and the ACE inhibitors, yes, we can continue on this drug if there is a decline in the kidney function by 30%. And this is a practice we all do in dealing with a cardiac patient or cardiorenal patient especially. But I want to confirm one information, important information. Whenever we have an injury, we cannot start these drugs. Although we know that it causes injury without dysfunction, but at the time of the ICU admission, when we have a kidney injury, we cannot start these drugs and assuming that it will not harm the patient more. No, I think it will harm the kidney. So we usually stop these drugs at the time of admission and resume it back when the kidney function regained back to normal. And my question to you, when to regain? Speaking about the ARBs and the ACE inhibitors, when to regain back to the normal baseline?
Yeah, you're bringing up a fantastic question, and the data are actually conflicting on that. So as you clearly point out, we agree with the practice that you're stating. If you're talking about a patient who has diabetes and some proteinuria, and you want to start your ACE and ARB that's not acutely ill, right? That's where we're talking about that permissive hypercreatinemia or the permissive acute kidney injury. When you're talking about a critically ill patient, as you point out, this is not the time to start seeing if we can alter their dysfunction along with whatever else they're receiving, right? We'll talk about bad drug combinations in a minute, but your next question about when to restart after a critical illness, there's debate in the literature. Some have suggested that you could have continued it, that you could have continued your ACE or ARB, that there's some data to suggest maybe we're not causing more damage. People at this point in time are still reluctant and do not continue them, as you point out. But the time to restart them is not clear because we don't have good data on the outcomes for when to restart them. It's pretty close to what you've said, which is once their renal function has improved after critical illness. So we're talking probably a couple weeks, 2 to 4 weeks after a critical illness, after they've been discharged from the ICU. You're following them up to see when you would want to restart those medications. But there's no clear answer to that based on evidence to suggest exactly when they should be restarted. So, but it is in clinical practice, as you speak of, which is when their renal function gets better after that critical illness, then it's restarted. But I would caution, that's only a good idea depending on what other medications that they're on anyways. Because if you're restarting it back and they're on other host of nephrotoxins, you could still result in some damage. So I think it's a careful consideration to not just say, okay, 2 to 4 weeks out, renal function looks good, let's restart it. 30% of patients who develop acute kidney injury go on to develop chronic kidney disease. And we're trying to get to understand why that is. Is it because of the drugs we've restarted? Is it because of them not being followed appropriately? What are the reasons that these patients go on to progress to CKD is not fully understood, and we're actually doing a lot of investigation to figure that part out. I don't know that I've had a perfect answer for your question. I think it's exactly like you're saying.
Yes. I think it has to be individualized according to the patient. Yes, the perfect answer is per patient.
Yeah.
Short question, short comment to continue the lecture, please.
Yeah, so I think it's interesting, and I do think we need to learn more about that, and we're very interested in the topic that you've just raised. So we were talking about tubular dysfunction. We're talking about glomerular disease, which can be from a lupus-like reaction, which can be hydralazine. Membranous disease, NSAIDs. So kind of interesting because NSAIDs are here, but I've also mentioned them up here with regards to some type of ATN. In actuality, they should be in the AIN category as well. So NSAIDs can have multiple ways to which to cause injury. And then we have nephrolysis, or tubular obstruction. The acyclovir, the sulfamethoxyl trimethoprim are in this category as well. So here you can see that I've highlighted some of the drugs in orange. And I've highlighted these is because we've done an assessment with some experts to do a modified Delphi to determine which drugs are perceived to be the most nephrotoxic. And these happen to be in our list, which I'll go over shortly, but that's why I highlighted these in orange. In addition, I just wanted to point out, that it's not listed here. I'm not sure why it's not coming up, but we have aminoglycosides, which are causing your direct acute tubular necrosis. We have cisplatin, which is 43 to 50% of patients, adults or peds. The metabolized is actually causing this reactive thiol resulting in tubular toxicity. We have acyclovir and sulfamethoxyl trimethoprim at the bottom here, which is causing that tubular obstruction from some crystallization as well. So different mechanisms for these different types of drugs. So when we go to the bottom corner, which is your dysfunction plus your injury, that's really where a lot of patients will start with the injury without dysfunction, but we don't really catch it quickly enough. And so you'll see that they'll quickly progress to dysfunction and injury. And so the interesting part, though, is that when you have a damaged biomarker, it can identify kidney injury about somewhere between 1 to 3 days before the rise in the serum creatinine. So we might have this opportunity to step in and intervene before we get to the type of dysfunction. Now, in dysfunction and injury, I put NSAIDs, and the answer to that is because as we know, it also, NSAIDs cause prostaglandin inhibition and can cause vasoconstriction of the afferent arteriole. So that's more of a hemodynamically mediated dysfunctional type of acute kidney injury. But as I just pointed out, they also cause injury from either ATN, AIN, or some different mechanisms. So they can cause various types of injury. So that's why I've categorized it in this dysfunction and injury box. So deleterious risk modifiers, I'm going to speak specifically about what is the nephrotoxic potential for each drug, what combinations pose the greatest risk, and what is nephrotoxic burden. So I mentioned to you that I have just completed a modified Delphi because I was curious on expert opinion. We've gathered opinions from both international physicians and pharmacists to better understand how nephrotoxins are ranked with regards to possible or probably nephrotoxic at this rating of 1.5. Probable potential is the potential for nephrotoxicity is probable with routine use, and that's a rating of 2. And the nephrotoxicity is probable to definite. So we asked these experts to rank on a scale of 0 to 3 how nephrotoxic they believe the drug to be. And you can see that I've only highlighted here the ones in the higher categories at 1.5, 2, and 2.5. And you can see the drugs listed here with regards to their rankings. And this was just literally published a couple of days ago if you're interested in seeing the results in more detail. So this is how nephrotoxic a drug is, could help you to decide, right, if a drug is more nephrotoxic than less nephrotoxic. Maybe in a particular patient who's at risk, you go with a drug that's considered to be less nephrotoxic. So understanding how nephrotoxic a drug is might help you make a clinical decision. When we're talking about which drugs to give together, that can also be a problem. It's come back to what the question was previously. When we start talking about the triple whammy, we start with, like, if a patient's receiving NSAIDs, that could be potentially nephrotoxic. But then when you put it on top of a patient who's receiving a diuretic, this increases the risk for developing acute kidney injury. We've discussed that NSAIDs can cause some inhibition of prostaglandins with the afferent vasoconstriction in the presence of maybe some global hypoperfusion from the diuretic or a less effective blood volume from the diuretic. This increases the risk for acute kidney injury. Now we get to the scenario where it's an ACE and ARB is added on. The triple whammy is added on to the NSAID plus the diuretic. And we know that that can actually cause some efferent vasodilation. So again, in a patient, if a patient's on all these other nephrotoxins, irrespective if you're imagining a functional decline, the burden that's going on with these patients, this drug combination given together, has a greater potential for increasing the risk for acute kidney injury, which can be concerning. If anybody's been following the vast amount of literature on pip/tazo and vancomycin in the last, say, 8 years, a lot of information has come out with suggesting that this combination has an increased risk for developing acute kidney injury. The mechanism is not entirely understood, but we have a lot of observational data that's suggestive that this does happen. And we think about pharmacokinetic drug interactions. We have drugs such as clarithromycin, which inhibit CYP3A4. We have some calcium channel blockers that are substrates for CYP3A4. So when the clarithromycin inhibits the metabolism, the calcium channel blockers concentration can increase and cause a global hypotension, increasing the risk for acute kidney injury. This particular observational trial compared and looked at, instead of clarithromycin, azithromycin, which doesn't have that CYP3A4 inhibition, and they saw a greater risk for acute kidney injury with the clarithromycin plus calcium channel blockers versus azithromycin plus the calcium channel blockers. So that's why this is suggestive to be a relevant drug interaction. We have calcium channel blockers that are also inhibitors of CYP3A4. Some statins are inhibitors or substrates of 3A4. You can increase the statin concentration, results in some rhabdomyolysis and acute kidney injury. Same thought with the macrolides plus the statins. Again, inhibitor, a substrate, increase in the statin concentration. So certain drug combinations can present a greater risk. This was a systematic review that I did with my colleagues. Here I'm just highlighting the drugs that have a moderate quality of evidence. There are other potential drug interactions that may be of concern that just had less evidence to support that the notion that they were interacting.
At this point, can I have a short question?
Sure.
Dr. Sandra, what kind of calcium channel blocker which interact with statin and cause kidney injury? And second question, to what extent colchicine can cause kidney dysfunction? Because we are now routinely use colchicine in coronary heart disease, in COVID, in pericarditis, in pleurisy. It have many applications. How long we can use colchicine? Some coronary, as I said, after stenting, you can use colchicine for longer term to prevent re-occlusion. So I'm worried the one you said it can cause kidney injury.
So I didn't say colchicine. In this particular case, I was talking about clarithromycin and calcium channel blockers. So I hadn't used the word colchicine. So although colchicine is getting more attention for its potential for acute kidney injury, you are correct. And then when we're talking about these, there's certain ones such as simvastatin. So clarithromycin plus simvastatin would be of concern. And there's another one, I think, the rosuvastatin as well. So there's a couple that are inhibited, and then there's like a couple that aren't. So you can make that choice accordingly with regards to your concern for this interaction. And again, you're right. You're talking about more of an outpatient basis because it's not like we're starting many of these drugs in the ICU. We're talking about the number of nephrotoxins is a struggle. I think this guy here is the example of this nephrotoxin is a struggle. He's struggling, right? And the kidney struggles the more nephrotoxins you put on board. So there is this additional odds of developing acute kidney injury for each additional nephrotoxin that's added, and this is a 40% increase in odds in this particular study. This study says is a concomitant administration is an independent risk factor for acute kidney injury. We have another study here that says a 53% greater odds. So time and time again, you'll see studies that say, look at more nephrotoxins, more burden, more stress on the kidney, more struggle for the kidney. And so previously I was talking about specific drug combinations may increase risk, but overall just the number of nephrotoxins increases that risk as well. There's a newer paper in the last year out of France that really goes into trying to do a calculation for drug burden and how much it increases the risk of developing acute kidney injury in critically ill patients. So this is just a general thought about, prevention of acute kidney injury. Assessing the risk can be associated with it aggregate, right? What the patient is receiving today is a burden. And then there's this cumulative thought about how many days they've received the furosemide, how many days they've received nalipro, how many days they've received the vancomycin. Altogether, that's a cumulative assessment. And, if this answer is 4 or 5 days for each one of them, that's increasing the struggle. That's increasing the burden, right? And so we can think in terms of, hey, the snapshot of what's just happening today, or probably more appropriate, we think of this cumulative exposure for all of them to get the true weighted burden. And then I'd also raise the point that just because a drug is discontinued for 24 hours doesn't mean there's not some in the system still having an effect. So if you're doing a daily assessment, you might want to see what had been recently discontinued. So we have these goals, which I call nephrotoxin stewardship. I want to stay on time. I've introduced this term and the thought of, we've heard of antibiotic stewardship, fluid stewardship. We've heard of different types of stewardship overall. And I'm introducing the idea of nephrotoxin stewardship because I believe that if we actually put in this coordinated, strategic management effort, that we could reduce acute kidney injury overall in the hospital. So what is it? It's a coordinated effort to ensure the kidney health, right? We don't want damage to happen to that kidney. And we can also do it by avoiding unnecessary costs. So I say that because this doesn't mean throwing all kinds of tests at the patient to make sure it doesn't happen, acute kidney injury doesn't happen. We want to do it in a cost-conscious manner as well. And so all this is to improve the use of nephrotoxins, renally eliminated drugs, and when we have a treatment, which hopefully we do sometime soon, we'll hope, then that would be incorporated in this as well. So what do I mean by safe medication use? I'm talking about appropriate dosing of drugs that are renally eliminated. I'm talking about avoiding over and underdosing. I'm going to stress the underdosing because we spend a lot of time making sure drugs are dosed appropriately when kidney function declines. But when kidney function improves after an acute illness, we sometimes forget about readjusting those drugs. And that's a therapeutic failure. So underdosing of drug is equally as important. So if you're someone who happens to have alerts at in your system where you can set up clinical decision support alerts to help you identify someone who is overdosed, I would encourage you to think about setting up alerts for underdosing as well. If we're talking about ensuring kidney health, that means making sure the patient doesn't get AKI, right? Prevent it from ever happening. I've already said that 30% of patients transition from AKI to CKD. Let's try to see why that's happening so maybe we can avoid this transition. If a patient has acute kidney injury, we want to make sure it doesn't get worse, or if they have CKD, we want to make sure it doesn't get worse. So again, our goal is to ensure the healthiest kidney possible. And again, doing it in a cost-conscious manner. Well, I brought up the notion of using damage biomarkers to assist in identifying injury. That doesn't mean to, test that biomarker every day to see what's happening with the patient, because that's going to get expensive. So you want to make sure you do it in an efficient manner, only those patients who are at risk or however you might go ahead and do that. So with regards to the kidney health summary, how do you manage these patients? We've talked about this idea of nephrotoxin stewardship. It would require standardizing a list of nephrotoxin drugs to target for hypersurveillance at your institution. Why would I say that? Because if I ask, you've asked me, you line up somebody else, ask them, and another person, we would all agree on which drugs are nephrotoxic, so to speak. Your opinion of which drugs are nephrotoxic is usually based on your experiences. And some in the literature, but based on experiences as well. So we would not all have the same list that we're monitoring. So you want to standardize this list for your institution to make sure everybody's on the same page. We have aminoglycosides and vancomycin, which they're nephrotoxic, but they're also renally cleared. So therapeutic drug monitoring is important for these particular drugs. I've mentioned drug interactions that you might want to look at as well. This concept of nephrotoxic burden. So again, when a patient's on 3 or more nephrotoxins, that's a good idea to step in and intervene, see if you can reduce some of the drugs that the patient's on with regards to nephrotoxins, maybe prevent them from progressing. You want to evaluate functional biomarkers to make sure drugs are dosed appropriately. We do that quite regularly, but that's part of this overall surveillance. Damage biomarkers can be beneficial. We're learning more about how to use them in practice. And of course, a transition of care protocol so that when someone has acute kidney injury, to see if we can prevent them from developing chronic kidney disease. And hopefully one day we'll see some treatment. If you've been watching the literature, there's a couple treatments that have been looked at with regards to sepsis-associated acute kidney injury, a little bit of data around using metformin, a little bit of data around using azithromycin. Again, no proof that it improves outcomes at this point in time, but these potential kidney treatments are being evaluated. So hopefully one day soon we'll have something to speak of. So overall, this is just summarizing what we've talked about. We've talked a lot about nephrotoxins, how you might classify them, how you could think about them slightly differently than just the concept of pre, intra, and post-renal. We've given a lot of consideration to deleterious risk factors, what puts a patient at risk, including nephrotoxic burden, including specific drug combinations. So if you really want to be proactive about preventing acute kidney injury from an institutional perspective, developing an aggressive nephrotoxin stewardship program could be of benefit in doing so. So that is overall my discussion for today with regards to classifying and thinking about nephrotoxins.